Pediatric Grand Rounds. I think in the essence of time, we'll go ahead and get started. Just a few housekeeping items to start off with. I'm Gayatri Shankar. I'm one of the general pediatricians here at ETSU, and we welcome you to Pediatric Grand Rounds. Remember, our sign-in process for those present in this room now is for you to call the number on the back table. And if this is the first time that you're calling it, you will also then later get a text which will identify you as the person associated with that number. But if you'll use your cell phone to call that number to get credit for the Grand Rounds, and please turn in your evaluations at the end of the session because this is essential for us for continuing the Grand Rounds presentation. It is my pleasure to introduce to you Dr. Jeremy Bradley, one of our chief residents. I think we can really and truly call Dr. Bradley one of our own. He did his undergraduate training here in ETSU, went on to join us for medical school at ETSU, and then is now in his third year of pediatric residency here with us and has done just a fabulous job through his time here with us, and we're really, really sorry to see him leave. He is one of our chief residents and plans to work in the area. Dr. Bradley has, during his time here, done wonderful things with student and resident education. When I think of Dr. Bradley, I think of the Sim Man, because really he has led high school students in the Sim Lab, and I see some students nodding and smiling here. I'm sure all of you have been through one Sim Lab or the other with Dr. Bradley. He has led our second years through Sim Lab, the third years through Sim Lab, has just done an awesome job. And he does that so well that he's actually been awarded our Caduceus Award for Resident of the Year for 2 years in a row in 2013 and 14, I believe, Dr. Bradley?
Just one time.
It
should have been two.
Should have been two.
But.
Oh, well, we're awarding him 2 times in a row. And he has also had numerous presentations at local, regional meetings. I think I was there at one of his first oral presentations at SSPR a few years ago. He is going to be talking today on constipation in the school-age child, and I am eagerly waiting to hear the talk. Dr. Bradley.
Thanks, Dr. J. So this is going to be my talk. It's going to be on constipation. I had a hard time thinking of what to do my grand rounds on, and second years, you'll understand that when it's time for you to pick a topic, because I kind of like everything. That's why I'm going to do general peds, because everything interests me. Didn't just have one thing that stuck out. So started thinking about all the things that we saw all the time. No matter where you are, ER, clinic, hospital, you see constipation. And we treat these kids all the time, and I wanted to make sure that I knew what I was doing when I was teaching or treating these kids, and then also why I was doing it that way and why we follow these kids in the way that we do. That's how I came up with the topic. I have nothing to disclose. So our goals and objectives for this presentation, talk about some background information, talk about some definitions of constipation, onchopresis, look at how we diagnose it, look at some red flags, some warning signs when you're going through your diagnosis, look at current treatments, and the prognosis. So just some background information because other than seeing it a whole lot, it seems like every kid has constipation issues. What are some other reasons why we need to make sure we're doing this correctly? And a study that was from 2008 looked at constipation in kids, and U.S. kids. There's 1.7 million children that suffer from constipation. That's just a ton of kids. And we all know that constipation leads to more hospital visits, more clinic visits, more complications. And they found that cost per year for constipated kids versus unconstipated kids is about $2,000 more each year. You look at that for 1.7 million kids, that's about $3.9 billion a year in healthcare costs for constipation. And another study done in 2011 followed these kids, 15-year cohort of constipated kids, non-constipated kids, and they found a 4-time increase in the medical costs for constipated kids. And these aren't kids with other comorbidities like thyroid issues or congenital gut issues that cause them to be constipated. This is just functional constipated kids. And also, it affects the kids too. This is just published February 2015 in the Journal of Pediatrics, looking at how quality of life, emotional performance are impaired in these kids that have constipation. And we see that in our clinic when you talk to the kids about it. So it's a very important topic. So this is according to the North American Society of Pediatric Gastroenterology, Hepatology, and Nutrition, what you need to do for constipation. Real simple, right? Just like a maze. But we'll focus on certain areas of it. Other areas of that is for the GI docs. If you look at the very beginning, constipation. So what is constipation? There's a few definitions out there. If you talk to the parents, they're not quite sure what constipation is. They're like, oh, he poops, so he's fine. Or he hasn't pooped in 1 day, so he's constipated. What is the real definition? So like I mentioned earlier, the North American Society, Pediatric, GI, Hepatology, Nutrition, the NAFSGAN, they put together a criteria diagnosis for kids less than 4 or equal to 4 and above. And that's what we're going to look at. It's greater than or equal to 4 years of age. So the Rome 3 definition. So this is an absence of any other pathology going on. And they need 2 more of the following for at least 2 months. And these are the things that we see, less than or equal to 2 defecations, 1 episode of fecal incontinence, retentive posturing, painful or hard bowel movements, large bowel movements, large diameter stools. And why it's called the Rome 3 definition is every so often all the GI guys get together in Rome, Italy, put together some criteria. This is the 3rd time they met, and that's why it's called the Rome 3 definition. Other definitions out there are just kind of more easily to look at, just difficulty with defecation for at least 2 weeks, causing some significant distress to the patient. And if you look back at the Rome 3 criteria, they mention at least 2 months of symptoms. Well, some people believe that's just going to delay treatment if you wait for 2 months when the kid's already having issues. Onchopresis is also another important factor with constipation, and it's a repeated involuntary fecal soiling, which can be a smear or even just a normal style bowel movement. And it's not caused by any organic defect or illness. It's usually caused just retentive constipation. The kids are withholding, having overflow incontinence. It's kind of just a diagram of that. You got your normal on the left. You get the chronic constipation with the hard stools. It dilates the rectal wall. And when you dilate the rectal wall, the nerves kind of lose their sensation, so the kids don't get that urge to stool. The longer that stool sits there, it's going to lose water to the body. It's going to get reabsorbed, so it's just going to get harder. And then it just gets even tougher to push out. And then you get softer stools. And behind there, when things overflow, the softer liquid stools get around the impacted stool, causes smearing, soiling. And children, they'll kind of withhold by contracting the gluteal muscles, stiffening their legs, and the parents might even describe this to you. And a lot of times, it's hard for the parents to understand your kid is constipated, so he's having what they think is diarrhea. So you really have to spend time, draw it out for them, get them to understand what's going on. The history and physical is real important, when everything started, how often they're pooping, what they're pooping. You can use the Bristol stool scale if you feel like it to help the parents really describe what's going on. And then you do a pretty complete review of systems. And the reason for that is to look for any red flags, which we'll get to in a little bit. You also want to focus on family dynamics, the kid's temperament, how the kid behaves, family history, all the important stuff, all the stuff you do on a lot of other visits. But you just want to make sure that you include everything. Growth curves, abdominal exam, perianal exam, lumbosacral region, neuromuscular. You don't want to miss anything, because when we look at the differential of what might be causing constipation, it's pretty broad. Imaging to diagnose it, I think we all understand that it's just a clinical diagnosis. You don't really need imaging. A lot of times ER, or even ourselves, if you're not quite sure what's causing the abdominal pain, you'll get You'll get some imaging, and then when a kid's getting worked up for something else, they find a whole bunch of stool on imaging. And I just got this off the internet. I don't know what the yellow arrows are pointing at, but you can see the kid's got a lot of poop in them. And we see this a lot, even when you're not looking for it. You're just doing a regular, x-ray for something else, and you see a lot of stool. So we got the definition, we got diagnosed. Are there any red flags, things you really need to watch out for, buzzwords? And that's the major role of the history and physical, is to make sure there's no other disorders going on that you don't want to miss. And there's a long list of alarm signs, things that you would think of. For me, just the other day in clinic, we had a kid coming in with abdominal pain, sounded like constipation. You could feel stool on physical exam. And the parents go, oh, he's also really hairy. And you look at him, he's just got this huge tuft of hair at his sacral area. Sure enough, he's got spina bifida occulta. Getting an MRI set up to find out what else is going on. So maybe his constipation isn't just, oh, he's a 5-year-old that's got constipation. It could be something else going on. So that's why you go through your review systems, ask all the pertinent questions, good history. See the growth chart there. It's also very important. Looking at other endocrine issues, metabolic issues. Here's a list of differentials. I'm not going to read them all out to you. It's a long list. You know most of them. We've seen a lot of them. There's some other things in there that I wouldn't have thought about, especially like your ingestions, your heavy metals, things that we don't see quite as often. But the list of red flags and the list of the differential is very vast. So you have to keep an open mind when you're checking out these kids with constipation. So if you go through your definition, you got it diagnosed, there's no red flags, so you're going to call them functional constipation. So what do you do for them? First you decide, maybe there's a fecal impaction, which the kind of the NASCAN Society describes that as a hard mass in the lower abdomen. Either identified on physical exam or by x-ray, however you come across it. And if there is, then maybe they need to get disimpacted before going on to this maintenance therapy. So we're going to talk about treatment now for the kid, just functional constipation, no other disorders going on that's causing it. And the treatment is pretty broad, from initial disimpaction, maintenance therapy, dietary education, some behavioral changes. And it will take a while. Sometimes the treatment's 6-7 months of medicine. So here's a list of the treatments. First thing first, disimpaction if you think it's there. As far as what we use, we're usually using enemas, using PO medicines, polyethylene glycol with or without electrolytes. That would be your Miralax, your Go Lightly. And as far as studies go, there are no placebo-controlled studies where you give a kid Miralax, you give a kid a placebo. But we know that what Miralax does and that it's safe, so that's why we use it. But there's no good studies on just why we use this medicine. Now, as far as which medicines to use, there are good studies there. And there's one recently, or not too recently, but looking at for disimpaction. Should you do an enema or should you do an oral polyethylene glycol? And they found that they're equivocal. So either one, if you use the oral medicine correctly. If we put that kid in the hospital for Go Lightly and they sip it and don't ever get as much in as they need to, it's not going to work as well. But if you use the polyethylene glycol correctly, it can be just as effective as using an enema. So that helps because kids, parents, sometimes they don't want to go the enema route, but then sometimes they don't want to go the nasal gastric route either. And then they work at different speeds too. So your enema is going to be rapid. A lot of docs, like if they got a real far down impaction, right in the rectal area, use an enema. If the problem's at the bottom, start at the bottom. Get it cleared out. And this just lists 2 of them: hypertonic sodium phosphate. That is our Fleet's enemas. Mineral oil. You can also use milk and molasses. They're all pretty similar. Usually depends on one, what the nurses want to do. They don't want to mix the milk and molasses sometimes. I don't blame them. It's pretty gross. and what the pharmacy has, what your hospital has. So we use a lot of Fleets enemas, Peds Fleets, because of what we have. The oral disimpaction medicines, you know, it's a little bit slower. The Go Lightly, the NG tube, it's going to take 24, 48 hours. If you're in the clinic and you send a kid home with just regular polyethylene glycol, no electrolytes, the Miralax, you know, it might take 3-4 days to really get that disimpaction. Now, if you look at the medicines they have listed for maintenance, this is after your disimpaction, or if you don't think there's a disimpaction or an impaction there. And at the studies that they've done, polyethylene glycol really is the highest recommended maintenance medicine. So Miralax, it's the best. It's been shown to be more effective than lactulose, milk with magnesia, mineral oils, all those. And it's also been proven to be safe. It's over the counter. A lot of times you prescribe to the kid and the grandma's like, oh yeah, I take that too. So the families are familiar with it. And it works very well. Some of the other options, lactulose in some of the studies has also been proven to be very effective and very safe for kids. So if they don't like Miralax, you can't get the polyethylene glycol, then lactulose is another option. And it's very important that once you get the disimpaction done and you're on maintenance medicines, routine enemas shouldn't be used for maintenance. If you're having to use routine enemas, then maybe something else is going on. Then you need to start seeing the GI doctor. If you look at what, it depends on where you read, your enema, you can do it for your disimpaction, you can do an enema once a day for the first 3 days, once a day for the first 6 days. Depends on what you look at. Anytime after that, you're still not disimpacted. They need a GI doc or a surgeon. And the parents need to understand that the process is going to take months. It's not a quick fix. You know, the enemas are quick, work there at the bottom, then you got the whole rest of the backup that you need to clear out. And another reason that the maintenance needs to go on for a long time, it's just because physiologically, the rectal wall is stretched out, and those nerves are losing their sensation. So months are really required for the rectum to return to a normal caliber to get that sensation of normal stooling. I know Dr. Aiken likes to use the balloon analogy. You blow a balloon up and you let the air out, it doesn't go right back to its normal size. It's kind of stretched out a little bit. And if you use that, then the parents start to understand that we need to be on this medicine for a while so like the rectal diameter goes back to normal. Because if it doesn't, the kid starts getting constipated again. He can hold a lot more stool down there. It's just going to keep happening. So you have to stress that the maintenance medicine is not PRN. It's daily, daily, and they need to titrate. And sometimes it's hard to explain to families what titrate means. You tell us what titrate means, we kind of understand. So you have to work it out for them. Stools start getting a little runny, cut down. Tell them how much, you know, a whole cap to a half cap, close follow-up so they know what you mean by titrate. Sometimes they mean give it or don't give it, is what their understanding is. And this is just another picture showing constipation, the stretched out rectal wall, and what to expect with recovery, which again takes months and months. Another huge part of treatment is dietary education. We tell all our families certain things, and I want to look into, you know, the studies behind it and why we tell them that. We always stress fiber, but how much fiber do you need to give them? The daily recommended value for kids, take their age in years, then 5 to 10 grams after that. So if you got a 5-year-old, they're going to need 10 to 15 grams of fiber daily. Adults need 25 to 30, depending on what you read. Now today I had cereal, cafeteria, it's 5 grams of fiber. Had a bag of Cheetos, which was only 1 gram of fiber. So I got a ways to go.
Thanks a whole lot. We need to know that.
Some studies have shown that only 12% of children actually get their daily recommended amount of fiber, which is almost none of them. And so we should recommend and encourage a diet that meets their daily requirements. There have been multiple studies that have failed to show benefit from increased fiber over your daily amount. So the kids need to get their daily amount. They don't necessarily need to get more than that to help with constipation. But the way we stress it to our kids, they're not getting their daily amount. So we need to stress to them to get more fiber in their diet. And what are some ways that we could do that? Well, of course, the AAP helps us out. They have great handouts. You know, more fiber for your kid. It's on their website. I'm going to start using it now that I've looked at it and know about it. It shows why to add more fiber, how to add more fiber, how much to add, how much your kid needs. They break down different food groups. They have different fiber content, different ways of sneaking fiber into kids' foods for those picky eaters. A really good handout. And that's the first page. This is part of the second page, which also goes into when you're looking at, you know, nutrition facts, where to find fiber at, so that the parents know where to look. And of course, as we all know, Mountain Dew doesn't have any fiber in it. Which is the main reason our kids aren't getting enough. But it's a very good resource. It's easy to find on the AAP website.
What is a good source?
Of fiber? Well, let's look. Sweet potatoes. If you're going to go beans and peas, they seem to be the most bang for your buck. Looking at black beans, 7.5 grams for a half cup. On the previous page, raspberries, almonds. But
I didn't think of sweet potato.
yeah, the beans definitely seem to be the best bang for your buck. Anything with whole grain bread will also be good too. They have done some studies looking at which kids might be more likely to get their fiber intake and which ones are less likely. And this study from 2006 found that medium income families actually are the least likely to meet their daily requirement intake of fiber. And I thought that was interesting, but it's because the low income families who participated in WIC are twice as likely to meet their daily requirement intakes than those that don't have WIC. And then there's another study looking at adults, that if us adults met our daily requirement, every single adult met their daily requirement of fiber, that possibly $1 billion to $12 billion could be saved annually on healthcare expenses. And also, penguins don't get enough fiber in their diet. Those are water. We always stress children to drink lots of water. That's because they just don't get enough. The studies have shown that there's no benefit for excess hydration, overhydration, but we all know that our kids are not drinking enough water as it is. My basketball coach used to tell me that if I'm not peeing clear, that I'm not drinking enough. So we need to stress that to the kids, not that they drink more than their recommended amount, but just so they actually get to their recommended amount of water to help not only with constipation, but just because it's what they need. And so far, they're doing a lot of studies right now on probiotics, constipation. There hasn't been any benefit shown. Now, we all know that behavior withholding, failures with toilet training, those can lead to certain child behaviors that's going to make them prone to being constipated, whether they're scared to stool because it hurt last time, or they got punished once for making a mess in their clothes when they're trying to be toilet trained. Using public toilets, they don't like it. Going to school, whether they're getting bullied about it or they're embarrassed to go at school, or they think that the school bathroom's not clean, or they don't have enough time. And the more the kid withholds, the longer that stool sits in the rectum and the colon, more water gets reabsorbed from it. And it's just a vicious cycle, because then it gets harder to push out. And there's a lot of reasons why the children decide to withhold. This is a case report from 1990 that was in the Journal of Pediatrics. It was a television commercial. There's like this 3 to 4 year old who was getting constipated. He would only stool standing up and in his diaper. He got treated for constipation. He relapsed. Then finally, after further questioning, found out he saw this commercial on TV of this monster toilet. And this company eventually had to pull the commercial from TV. Now, this is not that commercial. Does anyone know what this is from? This is the movie Look Who's Talking. This is Mr. Toilet Man that's going to eat your pee-pee. That's what the kids are scared of. Look it up on YouTube. It's pretty entertaining. And we definitely recommend a lot of behavioral modifications for the management of onchopresis, constipation, withholding, and that can be done, toilet time. Make sure you sit on the toilet after every meal, at least 10 minutes, if feasible. If the kid's at school, you're not really going to be able to do that. Maybe 20 minutes after supper. And that's really to take advantage of that gastric colic reflex that hits after you eat. And also to get the kids in a habit sitting on the toilet. Star charts are a good way. You reward them for sitting. You give them 1 star for just sitting on the toilet for the 10, 20 minutes. You give them another star if they also poop during that time. Good way to encourage toilet sitting and healthy bowel movements. The schools play a lot too, because a lot of times the kid spends most of their time at school than they do at home. And a lot of times kids don't like to use the bathroom at school, whether it be social fears, being embarrassed, getting bullied. Maybe they think the bathroom's unclean, they don't have enough time. Here's just a few studies. Found that the kids thought the toilets were unpleasant, dirty, smelly, frightening. Bullying occurred there, so they avoided using the bathroom at school. More recent one, kind of older kids, the teenage one for this study for 2005, that 25% of the children reported never using the bathroom to urinate at school. School days are a long period. I can't go that long. And then 80% never defecated at school for those same reasons. It's dirty, they're going to get bullied, they're embarrassed to. And there's a few studies I didn't put in here looking at, it's from the UK, looking at teachers' own recognition of what kids need. And there's about 30 to 40% of teachers said that they have prevented kids from going to the bathroom just so they can get through their lecture and finish the lecture. Now, looking at the studies for behavioral therapy, there's not a lot of them. There's one that was posted in Pediatrics in 2008, looking at a randomized controlled trial for behavioral therapy for childhood constipation. And it showed that behavioral therapy plus regular treatment and then versus regular treatment alone, that there wasn't much benefit. It's a very small study. The power wasn't very high. There's been a few other ones that have shown some benefit. And then the NAPSCAN recommend that you don't do, their wording is intensive behavioral therapy for functional constipation. But, as a caveat, they do recommend behavioral modification when there's behavioral issues present. So, the studies don't help us too much. We definitely encourage our behavioral health people to come help us out when you have withholding, toilet avoidance, things like that, to help with the behavioral aspect of it. And we're a lot taller than the kids are. Our feet are on the ground. Sometimes kids' feet aren't on the ground. So that's not ideal. This is ideal, so that they can get a good Valsalva going. Then also, when they're doing that sitting for 10, 20 minutes, some say, give them a book, give them a video game to play, whatever gets them sitting on the toilet. Others say they should be distraction-free, so they can just concentrate on pooping. Kids these days, it's hard for them to sit still without any distractions going on. That's still up in the air. Now, I can see that some of y'all are a little jealous that these kids get nice stools to put their feet on. But don't worry, because recently the company, the Squatty Potty, has came out for adults. Healthy colon, happy life. And like I said, I have nothing to disclose. I have no investment in this company. So they were on Shark Tank not too long ago, which is the show where people come present their ideas to these people that have made a lot of money. And what their belief is that adults, everyone, needs a 36-degree angle to use the restroom. And go to their website, it's very informative. Poop like a pro. And for those who are interested, and kind of like the fancier versions, they have bamboo. If you get two, you get $10 off. So you get two for $70 each. Now, just kind of looking at everything again. So you got a kid that comes in with this history that sounds like constipation. The physical looks like constipation. You don't have any red flags anywhere. You talk to him about adequate diet so that he gets enough fiber, enough water. Go over some behavioral modifications. Maybe he's got some withholding. talk to the parents about it so they understand what's going on. If they need it disimpaction, you got them disimpacted, and then you put them on a maintenance medicine. And then what do? So back to our maze here. Hope everyone followed. So we're up there at the top now. Evaluate after 2 weeks, treatment effective. And if it is great, keep on the maintenance therapy. For how long? A lot of studies say at least 6 months, especially if they had onchopresis and fecal impaction. And that's for that physiologic return of the normal rectal caliber that we were talking about. If it's not working, maybe you got to look into why. Are they doing the medicine right? Are they doing it at all? Are they doing the behavioral modifications? Reassess. Was there red flags that you missed, that you weren't aware of, that the parents weren't aware of? Okay? And it's kind of, you just keep trying things. Eventually, if you treat them, they're not getting better, they're using it right, they're doing anything correctly, there doesn't seem to be any apparent red flags, then that's when you need to send them to a GI doc. If they're truly doing everything you're asking them and things aren't getting better, maybe there's something else going on, needs some specialist involvement. Also, if you have that kid that just keeps relapsing over and over, even though they're doing everything correctly, they need to see the GI doctor also, just to make sure there's nothing else going on. And now if we look at these kids do great. How does it work out for them? And we talked about the prognosis and that it can take months. 50% of kids with onchopresis, they seem to have a recurrence at least once. That's a high amount. And then a study from 2010 from Pediatrics, 25% of kids with functional constipation, so that's constipation not caused by anything else, no other medical issues that's causing it, continue to have constipation to adult age. And it turns out to be a lot of children coming into adults with a lot of medical costs. And we all know that constipation can lead to other things, so UTIs, hemorrhoids, diverticulitis. It's not just benign. It's not just because it's hard to poop. It does cause some medical concerns. So I flew through that a lot quicker than I thought I would. When I practiced, that did not take that short amount of time. So I got a few more slides after this one, but I want to know if anyone had any questions before we kept going.
Did anything on like the AAP talk about adding in things like the biomarkers and anything that are somewhat better flavor? Because I know a lot of these kids that we start out trying to increase the fiber, they're already clean eaters. So this way they get a high dose of fiber in one bar, relatively tasty, and kind of trick them a little bit. And basically they say anything about.
All they really recommend is they get the daily required amount of fiber. They didn't really go into how you get it in them, as long as they get it. They talk about adding nuts in here, berries in here to certain things, as long as they get that adequate amount. They haven't done studies on, should they only eat fiber bars or should they get it all through fruits. And one thing that we always tell the kids too, or the parents, is eat your fruits, don't drink your fruits, because the fruit juice and everything don't have any fiber in it, but if you eat your fruits and your veggies, they do. Anyone else with any questions?
You asked them about how much milk
Yeah, so from what I found, as far as what you eat, we always see the kids that eat a whole bunch of cheese, eat a whole bunch of bread, things like that. There wasn't a lot of studies out there as if that's bad, but what they're tying it into is that because they're eating all mac and cheese, they're not getting enough fiber, and that might be playing a role into it. So if you encourage them to have a well-rounded diet, which is not going to be mac and cheese every meal, then it should help. As far as dairy products, they are thinking that if you have a kid that keeps relapsing or doesn't help with treatment, just stays constipated, to do a trial off of dairy and see what happens. And it could be a milk protein allergy that was undiagnosed. As far as tablets, I'm not sure, there's fiber bars, there's Metamucil, there's a lot of over-the-counter products to add fiber in. And there's also a lot of nutritional ways of sneaking it in, like that guideline or the handout says, adding nuts here and there, adding like chia seeds, and what's the other big little flax seeds, adding flax seeds on top of things, which are basically tasteless, way to sneak in extra fiber. I didn't look into it because I was looking at school-age kids, but I've seen it, and I've used it at 9 months. And I believe there's one of the doctors in the clinic that said they've seen some studies that safe at 9 months.
I heard of that saying 6 months is okay.
6 months. There you go. All right. Any other burning questions? Now that we have all this information, we know what we should be telling the families. How would there be a good way to get this information out there? What would be the best way to prevent all this information, to encourage a healthy, active lifestyle for the colon? These are my thoughts. We already have an amazing way of getting tip-supported guidance to families with the Read and Play program. It's completely awesome. Everyone's enjoying it. We already do dietary guidance with it. You know, whole grain cereals instead of sugar, strawberries and bananas. But how can we expand this maybe to something more? So my thoughts would be to expand it to a Read and Poo program so that we can encourage the kids to read while sitting on the toilet. Give them books so we can stomp out constipation and illiteracy one flesh at a time. So interns, if you're looking for a new project, this would be something good to do.
You're not afraid of hemorrhoids?
There's some of my references to go along with all the other studies I mentioned. Thanks.
I'm glad you mentioned UTI and dysfunctional voiding and accidents. Accidents always could be related to constipation.
Yeah. Mm-hmm. All right. And one thing I meant to mention during the history part, when I first started, I used to say, "Hey, are you pooping okay?" And they're like, "Yeah." They don't know what pooping okay is. So you need to ask them every day, multiple times a day, once a week. Is the mom having to use a broom handle to break it up so it'll go down the toilet? You got to be specific because they might think that's normal. But to us, it's not normal. Okay. Yeah. And you got the parents that think, you know, they're pooping every day, so they're fine. But it's large caliber, or they're having pain. That's all I got. That's all I know about poop.